Hello coders! Today we're going to start our chapter-specific coding guidelines with chapter 1, which is certain infectious and parasitic diseases. These are codes A00 to B99. So what we're going to do is we're going to go through the guidelines. As we go through the guidelines, we're going to be flipping back and forth from the guidelines to ICD10data.com to look at the codes. Then when we finish all the guidelines, we'll do a little breakdown of what's in each section and kind of the main terms that you might want to look for. So we have a couple of main chunks that we're going to have to get through. We're going to talk about HIV. We're going to talk about sepsis and severe sepsis, septic shock, and we're going to talk about how we code for certain diseases such as MRSA and MISA. So we're going to start with number 1, which is code only confirmed cases of HIV infection. Now, this is an exception to the hospital inpatient guideline, and this is an exception because of what you see in the green. In this context, confirmation does not require documentation of positive serology or culture for HIV. The provider's diagnostic statement that the patient is HIV positive or has an HIV-related illness is sufficient. So this is for a couple of reasons. Number 1, it usually takes a minimum of about 72 hours to get the positive serology or culture back from the lab. So if this is a walk-in clinic, if this is the emergency department, and a patient comes in and says, I'm HIV positive, or we already know the patient's HIV positive because we have documentation, we don't need to do a culture or a serology test every single time. So that's why it's different, because usually we code for absolute confirmation on the hospital inpatient guidelines. For the outpatient side, we still go with this confirmation either way. So if the provider says the patient's HIV positive or is an HIV-related illness, we code for it. What we need to be careful for is whether or not the patient is currently having or has ever had a complication, or if they are just an HIV status. So, when we're talking about admission, if a patient is admitted for an HIV-related condition, the principal diagnosis should be B20, human immunodeficiency virus, followed by additional codes for all reported HIV-related conditions. So if a patient's being admitted because of pneumonia or bronchitis, or another type of infection, a fungal infection, Kaposi sarcoma, other types of leukemias, the HIV should go first, okay, because that is the cause. The effect is the HIV-related conditions. Remember, patients that have HIV, what brings them from HIV into AIDS status is their lack of T cells in their body. And so what happens is, as they continue to lose those T cells, which are part of our natural acquired immunity, they are not able to fight any infections. So something simple as a cold could in fact end up making someone admitted to the hospital because, again, their body can't fight the infection. So we need to know that this is an HIV-related condition. Some of them are always related, some of them are not. And again, how do you know whether they're related or not? Well, a couple different ways. Number 1 is doing some simple research. Websites such as WebMD is really good for some basic research. Also, medicinenet.com, which is actually owned by WebMD now, they have a lot of really great information, and it's very clear. And so as a coder, you want to have at least some basic knowledge on what these conditions could be. And if you're coding for it in the real world, then you do want to always do your research to make sure that you know. Remember, doing research in the field is part of what we do. So there's nothing wrong about you not knowing whether or not it's an HIV complication. It'll be up to you to find out whether or not it's an HIV complication. However, sometimes we know it's completely unrelated, and that's what we see in B. If a patient with HIV disease is admitted for an unrelated condition, such as a traumatic injury, the code for the unrelated condition, the nature of the injury code, should be the principal diagnosis. Other diagnoses would be B20, followed by additional diagnosis codes for all reported HIV-related conditions. So again, if we know the patient has had complications with their HIV in the past, or if they're in AIDS status and they have a traumatic injury, they have a fall, they fracture their wrist, the fracture of the wrist will go first, then the B20, then any other HIV-related conditions. Now, what we have to keep in mind is, as it says, whether the patient is newly diagnosed or has previous encounters for an HIV condition is irrelevant to the sequencing decision. It does not matter when the patient found out they have HIV. It depends on the reason why they're having the encounter. What we really need to know is whether the patient is asymptomatic or symptomatic. So we have code Z21, asymptomatic human immunodeficiency virus infection status, is to be applied when the patient without any documentation of symptoms is listed as being HIV positive, known HIV, HIV test positive, or certain terminology. Do not use this code if the term AIDS is used or if the patient is treated for any HIV-related illness described as having a condition resulting from his or her HIV positive status. Use B20 in these cases. So again, asymptomatic, no symptoms. So Z21 is the status. This is HIV status. This means the person has HIV in their body. They do not currently have a sickness that's associated with HIV. They've never had an HIV-related illness. So Z21 is what we use in those cases. However, again, if they use the term AIDS or they describe HIV with complications, or we've used the code B20 before, we do not then use Z21. So when we're looking over here, over here. So again, B20, human immunodeficiency virus. Okay. Again, we use additional codes to identify all manifestations of the HIV infection. And again, we have a couple of other codes that it leads us to. We're going to, we have the Z21 for the infection status as an excludes one, exposure to the HIV virus, as well as the inconclusive serologic evidence. We're going to talk about that in just a minute. And you'll notice that the B20 includes AIDS, AIDS-related condition, which is known as ARC, and symptomatic infections. And again, it goes on to give us a lot of different types. Now, on ICD-10 data, they go into a little bit more and give us some information. Again, things that we might see are going to be things like lymphadenopathy, fever and weight loss, chronic diarrhea, opportunistic infections. Most HIV patients will die of opportunistic infections. Some of them will die of things like lymphoma and sarcomas, but man, the big thing to remember with HIV is you don't die from HIV. You die from whatever is complicating the HIV, which is usually an infection, but could be a lymphoma or sarcoma or something like that. Now, the other thing that we want to remember about this is, again, they put right here. So if you want to know specifically what puts someone into B20 status, it is a test for CD4 positive T lymphocyte count that is underneath 200 cells per microliter, or less than 14% of total lymphocytes. So that means that for someone to be considered in AIDS status, what we do, again, we do a series of lab tests, and they can actually tell by the T cell count, because as HIV progresses, that person loses more T cells and the ability to create T cells. So again, you can go on this type of website to get extra information, or you can go on another type of medical website to get even more information. Now, the Z21, again, the big thing here is, again, we would code first if there's a pregnancy-related condition. However, it excludes, again, the actual HIV with symptoms, the contact and exposures, as well as the inconclusive. And so, again, this is the asymptomatic. So it goes on to let us know. Patients with inconclusive HIV serology but no definitive diagnosis or manifestations of the illness may be assigned code R75, inconclusive laboratory evidence of human immunodeficiency virus. So there are two main ways that we check for HIV. The first one is through mucous membrane swabs. So again, we have something called the OraQuick. It is a self-encapsulated unit, looks like a mini pregnancy test, but what it does is it pops open and you swab the inner side of the patient's cheek. And you get those mucous membranes and you pop it back together. About 10 to 15 minutes later, it gives a preliminary test. So again, positive or negative. However, then that gets sent to the lab for the definitive. Well, here's the problem. Sometimes with that type of testing, we don't get enough mucous membranes. So when the lab gets it, they can't tell. That's the inconclusive, the we don't know. And so in this case, we would use R75 for a return to the lab to probably do the blood test, because the blood tests are definitely conclusive. And those, again, are done usually with either a yearly physical. They can also be done with an STD screening. They could be done at the time of a pap smear. So, keep in mind, there are different ways we might see the inconclusive test, but really the people who are going to see the R75 is going to be the people who are coding for the return to the lab. Now, as it lets us know, patients with any known prior diagnosis of an HIV-related illness should be coded to B20. Once a patient has developed an HIV-related illness, the patient should always be assigned code B20 on every subsequent admission. Patients previously diagnosed with an HIV illness should never be assigned to R75 or Z21, asymptomatic human immunodeficiency virus infection status. So again, once you move from Z21 to B20, you stay a B20 for the rest of your life. So even if it's been 10 years since the person had an HIV-related complication, they are still a B20. Okay, and this is where we need clarification sometimes. If the doctor puts AIDS, that's clarification, that's B20. If they put HIV, we need to know, again, going back in the system, what's been coded before, if we've never seen them, going into the record or querying the physician and saying, okay, is it HIV positive status or have they had complications? Now, during pregnancy, childbirth, or the puerperium, a patient admitted or presenting for a healthcare encounter because of an HIV-related illness should receive a principal diagnosis code of 098.7, HIV disease complicating pregnancy, childbirth, and the puerperium, followed by B20 and the HIV-related illnesses. Codes from Chapter 15 always take sequencing priority. And when you get to the O codes, that is the first thing it says under the O codes, which are Chapter 15. When a woman is pregnant, an O code, 99 times out of 100 will go first. There's a couple of circumstances in the pregnancy guidelines where you'll see we put a Z code first. But in this case, if she has had an HIV complication and she is pregnant, then we are going to use a B20. However, patients with asymptomatic HIV infection status admitted or presenting for a healthcare encounter during pregnancy, childbirth, or the puerperium should receive codes of 098.7 and Z21. So again, we need to know, is mom HIV positive, Z21, or HIV complication, which is B20. Now, here's something that's kind of interesting. There's a cocktail of drugs that a woman can take now that will block the HIV virus from crossing over the placental border into the baby. So we have a lot of HIV positive moms giving birth to HIV negative babies. However, for those women where maybe they found out too late or they just couldn't get the drugs or whatever it might be, there's been a couple of studies done in the last couple of years where they've given high antiviral therapy to the child from the day they're born up to age 2, and they've been able to basically reboot and eradicate the HIV virus from their body. So although we will probably still consistently see, pregnant women that have an HIV status of some sort, we are seeing much less HIV positive children being born because of the two different therapies. And so I just want you to kind of keep that in mind. We're still going to see this on occasion, but there is hope with these different drugs and therapies. Now, again, a lot of people are going to get an HIV test done at a yearly physical, at a pap smear, or because they've had a recent encounter where they want an STD screen. So if the patient is being seen to determine his or her HIV status, we use code Z11.4, Encounter for Screening of the Human Immunodeficiency Virus. Okay, we also use additional codes for any associated high-risk behavior. Okay, so there's a couple of different types of high-risk behavior that we may put down. The main high-risk behavior is intravenous drug use. That's one of the main ways that HIV still spreads, is people sharing needles. Where I live, in my state, we have needle exchange programs in every major city. Not every state, not every area of every state has things like that. And even though we have these programs, we still see new cases of HIV. And so, again, some of it's coming from intravenous drug use and needle sharing. The other is still coming from sexual intercourse. So, again, high-risk behaviors can be both needle sharing and high-risk sexual behavior, meaning not using protection of any sort or having a lot of partners in a short period of time. Most physicians, if someone is single or considers themselves single, so, having 2, 3, even up to 5 partners within, say, like a year would be kind of normal for someone who's kind of in that single-ish, area. But when it kind of comes to, if people start talking about 10 or they can't remember or I'm not sure, then, that also, with those conversations with their physician, could also indicate high-risk sexual behavior. And so, again, it's a little bit A, a little bit of B. Mostly it's unprotected sex, though, because, again, most of the time, contraceptive methods will work against HIV and not allow that HIV virus to be passed on from person to person. So that's something to kind of keep in mind. The other thing is if a patient with signs or symptoms is being seen for HIV testing, we code the signs and symptoms. So again, if they have signs and symptoms of HIV, then we can code them. But again, what's in the documentation? An additional counseling code Z71.7, Human Immunodeficiency Virus Counseling, may be used if counseling is provided during the encounter for the test. So again, a lot of times if someone is really worried about this, what they're going to do is they're going to do some counseling with that patient. And they're going to see, do they have a support structure? Just about every major medical facility has some form of support structure for HIV positive patients. A lot of communities have them too. And so does that person know about them? And if they are positive, getting them in touch with those. So that's a lot of what they do during HIV counseling. And then obviously talking about barriers to ensure that you're not going to get HIV if, let's say, things come out negative. Now, this is a federal law. If a patient goes to a facility to get an HIV test done, they have to go back to that facility to get the results. Physically go back. They cannot call over the phone or get the results through the mail. They need to be told in person. And there's a couple of reasons why. Number one, because if a patient finds out they're HIV positive, again, there are these support structures, both, in the community and online that we can connect people to. Also, that patient's going to need to be hooked up with an infectious disease doctor. And so, again, we want to make sure that we're getting all of that information. Even if it's negative, patient still has to come in and get the results physically. The only way around this is if a patient does one of those mail-away kits. And the mail-away kits are not 100% anonymous. You still have to give a social security number with them because it's one of our mandatory reportings. Every new HIV case, it's a mandatory reporting to the state. The state then sends it on to the federal government, who makes sure that places like the CDC have that information. So, when a patient returns to be informed of his or her HIV test results, and the test result is negative, we also use code Z71.7 for the counseling. Okay, if the results are positive, see previous guidelines to assign codes as appropriate. Again, are they in the Z21 or the B20? So let's look at these for a second. So, okay. So again, we've looked at the Z21. Now we have Z11.4, again, encounter for screening of human immunodeficiency virus. It's an easy Z code. Again, this is also known as screening for HIV. And so again, what we're going to see here is we're going to see the excludes for extra information. So Z11.3 is talking about encounter for infections with a predominant sexual mode of transmission. So that would be for other types of STDs, right? That would be for things like syphilis, gonorrhea, chlamydia, herpes, HPV. Z11.4 is specifically for human immunodeficiency virus. So again, you'll find it under screening, and then you'll usually find it under disease. You can find it under viral, human immunodeficiency virus, or just under screening human immunodeficiency virus. Then we get to Z71.7. Again, this is going to be used for our counseling, whether it is before the patient gets their results or when the patient comes back to get negative results. Again, we have, again, HIV counseling, and what we're going to see here is we can look under either admission for counseling HIV, or under counseling HIV, or under HIV, human immunodeficiency virus. Even though it's not a proper eponym, we still have it as a search term. Okay, so when it comes to HIV, biggest things to know: symptomatic, asymptomatic, or are they coming in to get a test done? That's when we're going to have the counseling and the screenings. Also, again, don't forget, if you work for a lab, that inconclusive serology code R75 is going to come back, and you're going to see that on occasion when the testing is inconclusive. Okay, so the next set of guidelines is about infectious diseases classified to other chapters. Okay, so certain infections are classified in chapters other than Chapter 1, and no organism is identified as the infection code. So again, pneumonia, but we have it specifically will say pneumonia due to RSV, respiratory syncytial virus. Well, we look up pneumonia due to, we don't find it. So what do we do? In these instances, it is necessary to use an additional code from Chapter 1 to identify the organism. A code from category B95, Streptococcus, Staphylococcus, and Enterococcus as the cause of diseases classified to other chapters. B96, other bacterial agents as a cause of disease classified to other chapters. Or B97, viral agents as the disease as the cause of disease classified to other chapters, is to be used as an additional code to identify the organism. An instructional note will be found at the infection code advising that an additional organism code is required. Okay, so what I'm going to do is I'm going to go back here and let's look at some of the J codes. Okay, so let's look at, okay, so J17, pneumonia and diseases classified elsewhere. So if you end up getting to J17, okay, what we're going to end up seeing is you're going to see code first underlying disease, such as, and they give you a couple, and you'll see here, these are some of them. There's a whole bunch of excludes because, again, this is in diseases classified elsewhere. So it'll tell us we have to code first. So what we would end up doing is we would end up going back and we would look into the B95 to B97s. So some of these are going to be very, very specific. So as we get to the B95s, okay, so some of them are very specific. Streptococcus group A, Streptococcus group B, Enterococcus. But then we have other Streptococcus, unspecified. We're going to see MRSA here. We're going to see MISA as we continue going through. So let's look at the B96s. So again, other bacterial agents, we have things like Klebsiella pneumoniae, E. coli, Haemophilus influenza, Clostridium, Helicobacter pylori. So again, all different bacterias are under B95 and B96. B97 is going to be our viral agents. And so again, if we have a specific code for the specific bacterial or viral agent, we're going to code to that specific B95 to B97 code. However, if we don't and we still know, that's where our other specified is going to come in. So like for instance, if we look at B97.19, other enterovirus is the disease classified elsewhere. So if they tell us that it's a specific enterovirus and we look through and we don't have it in the B97s, we use the other specified. Remember, other specified is used for when we know what the exact issue is, but there's no exact code. So let's kind of keep that in mind. So again, you will see notations at these codes that will tell you code first, and then they'll send you back to the B95 to B97 codes. Other things to keep in mind. Many bacterial infections are resistant to current antibiotics. It is necessary to identify all infections documented as antibiotic resistant. Assign a code from category Z16, resistance to antimicrobial drugs, following the infection code only if the infection code does not identify drug resistance. Okay, so again, this needs to be documented by the provider. Also, keep in mind we have certain diseases that are already resistant, like MRSA, which is methicillin-resistant Staphylococcus aureus. So the methicillin resistance, we don't use Z16. We'll see that guideline in just a little bit. But again, we need a very direct and clear piece of information from the provider that this specific infection is resistant to antimicrobial drugs, and then we can assign a Z16 code. Now, this next set of codes, this is going to be more coding for the inpatient side. However, you never know when this is going to come up on a certification or credentialing exam, or you may be taking the inpatient certification or credentialing exam. So this is all about sequencing. What goes first, what goes second. And keep in mind, the more notes that you make in your guidelines, you can make little notes on the side. In my actual code book, I have notes on the side of each of my guidelines for sequencing. Put this first, put this second, put this third, and tab those areas so that you can easily get there. So when you have a question, you can remember that there's a guideline for sepsis. So we're going to be talking about sepsis, severe sepsis, septic shock. So this is kind of how it goes. Sepsis is blood poisoning. So that means that some type of organism, virus, bacteria, fungi, got into the blood and has reproduced so much that it's starting to take over the body. So that's sepsis. Severe sepsis is blood poisoning with organ failure. It can be any organ. Most common organ is kidney failure, because remember, as the blood comes down from the descending aorta, the first major branch are the renal arteries. And so it's very common that this infection that's in the blood gets into the kidneys, starts to shut down the kidneys. But severe sepsis can be any organ failure. However, septic shock is a little different. Septic shock is severe sepsis, but specifically with circulatory failure. Okay, and so that's a very specific failure that we're going to code for. So we're going to start with how do we code for sepsis, then how do we code for severe sepsis, then septic shock. So for a diagnosis of sepsis, the appropriate code for the underlying systemic infection, if the type of infection or causal organism is not further specified, assign code A41.9, sepsis unspecified organism. So what we're going to do, if we know the organism, we're going to look up sepsis and then what's the specified organism. When we don't know, again, not all blood testing is going to give us the exact answer the first time we want it. We may have to use A41.9. Now, it goes on, a code from subcategory R65.2, severe sepsis should not be assigned unless severe sepsis or an associated acute organ dysfunction is documented. So again, remember, sepsis is just an agent that is a microorganism agent that is in the blood and that is causing problems. Severe sepsis is that same agent causing problems in the bloodstream and then shutting down an organ or more than one organ. So let's look at our alphabetic index. So, I have to go back to the main page here. So what we're going to do is we're going to look up sepsis. So I'm going to go to the index. I'm going to go to S. And we're just going to scroll down. We could look this up, but it's not that far down. So again, sepsis right here. So when I click on this, you'll see all the different types, okay, of sepsis. So the unspecified is going to be up here. When we know what's causing it, again, we're going to use one of our subterms. And there are a lot of them, as you can see me just scrolling through. Okay, so if someone just has sepsis, we code to the specific type of sepsis. If we don't know the organism, we go for A41.9. Now, this is what we have to remember. Negative or inconclusive blood cultures and sepsis, negative or inconclusive blood cultures do not preclude a diagnosis of sepsis in a patient with clinical evidence of the condition. However, the provider should be queried. So again, just because we don't know the organism or just because we don't have confirmation that the patient actually has sepsis doesn't mean the patient doesn't have sepsis. So again, we need to be clear with the provider. The other thing is the term urosepsis is a non-specific term. It is not to be considered synonymous with sepsis. It has no default code in the alphabetic index. Should a provider use this term, he or she must be queried for clarification, because urosepsis usually means a urinary tract infection. So a urinary tract infection is not the same thing as sepsis, but they could be saying urosepsis in telling us that there's sepsis with kidney failure, but they need to state that outright. So that's why you have to query them for clarification. So if they do have sepsis with organ dysfunction, as they tell us, if a patient has sepsis and acute organ dysfunction or multiple organ dysfunction, which is known as MOD, follow the instructions for coding severe sepsis. So again, we need to be clear whether it's sepsis or severe sepsis. If it's severe sepsis, we need to know what organ or organs are being affected by the sepsis. Now, if the patient has sepsis and acute organ dysfunction, but the medical record documentation indicates the acute organ dysfunction is related to a medical condition other than sepsis, do not assign a code from subcategory R65.2, severe sepsis. An acute organ dysfunction must be associated with sepsis in order to assign the severe sepsis code. If the documentation is not clear as to whether an acute organ dysfunction is related to sepsis or another medical condition, query the provider. So for instance, if the patient was admitted for sepsis, and we look in the record and it says chronic kidney disease stage 4, the chronic kidney disease was not caused by the sepsis. They had the chronic kidney disease before the sepsis. So then we would code sepsis, chronic kidney disease. But the patient was admitted with sepsis, and then after that they went into kidney failure, then we could say, okay, that is severe sepsis, but we need that documentation by the provider to connect any organ failure with the sepsis. So the coding of severe sepsis requires a minimum of 2 codes. First, a code for the underlying systemic infection, what's the cause, followed by a code from subcategory R65.2, severe sepsis. If the causal organism is not documented, assign code A41.9, sepsis unspecified organism for the infection. Additional codes for the acute organ dysfunction are also required. Due to the complex nature of severe sepsis, some cases may require querying the provider prior to assignment of the codes. Again, this is where we need that connection. So let's look at that R65 code. So the R65 codes, over here. So we have R65.1, which is SIRS. That's different. SIRS is a non-infectious origin condition. We're looking down here at R65.2. So we have R65.20, which is severe sepsis without septic shock, R65.21, severe sepsis with septic shock. So again, R65.2, if it's without septic shock, then we're going to do 20. And then we're going to code the organ dysfunction. So what ends up happening is, let's go to this code. I want to show you guys. There's going to be a code first and a use additional. Okay, so down here. Oh, where is it? Okay, so in your book, it's not really showing on this particular website right now, but in this book, you're going to have a code first underlying condition or underlying infection, and then code additional for the acute organ dysfunction. So again, this is only for severe sepsis. So septic shock, as we're going to read, is specific to circulatory failure. Okay, so as we go back to the guidelines, kind of keep that in mind. So if it's severe sepsis, we need to make sure it is not circulatory failure. So as we go on, septic shock generally refers to circulatory failure associated with severe sepsis, and therefore it represents a type of acute organ dysfunction. For cases of septic shock, the code for the systemic infection should be sequenced first, followed by code R65.21, severe sepsis with septic shock, or code T81.12, post-procedural septic shock. An additional code for the other acute organ dysfunction should also be assigned. As noted in the sequencing instructions in the tabular list, the code for septic shock cannot be assigned as a principal diagnosis. So septic shock, again, which is R6521, we still have to code first the underlying infection. Then it's either going to be R6521 or T8112. So again, if the patient's being admitted to the hospital and we have no history of any surgeries lately, then we are not going to deal with the post-procedural. So again, the biggest thing with sepsis, severe sepsis, septic shock is clarification from the provider about when the sepsis occurred, what body systems and organ systems are involved, and is there any failure. Goes on to remind us, if severe sepsis is present on admission and meets the definition of principal diagnosis, the underlying systemic infection should be assigned as the principal diagnosis, followed by the appropriate code from subcategory R65.2 as required by the sequencing rules in the tabular list. A code from subcategory R65.2 can never be assigned as a principal diagnosis. So again, underlying infection, then R65.2 something. Then if there is organ failure, the organ failure. So also talking about when severe sepsis develops during an encounter, so it was not present on admission, the underlying systemic infection and the appropriate code from subcategory R65.2 should be assigned as secondary diagnoses because that's not what they were admitted for. We still code it, and we code it in the same manner, underlying infection, R65.2, and then the organ failure. However, again, were they admitted with it, or did it happen afterwards? That's where the sequencing is going to come in. What was the reason for admission? Now, severe sepsis may not be present on admission, and the diagnosis may not be confirmed until sometime after admission. If the documentation is not clear whether severe sepsis was present on admission, the provider should be queried. Again, we need clarification about when this all happened. So, in this case, if the reason for the admission is both sepsis or severe sepsis and localized infections such as pneumonia or cellulitis, a code for the underlying systemic infection should be assigned first, and the code for the localized infection should be assigned as a secondary diagnosis. Okay, so if the patient has severe sepsis, a code from subcategory R65.2 should also be assigned as a secondary diagnosis. So if the patient is admitted with a localized infection, such as pneumonia, and sepsis, severe sepsis doesn't develop until after admission, the localized infection should be assigned first, followed by the appropriate sepsis or severe sepsis codes. So again, pneumonia, cellulitis is another big one. Again, things like gangrene on a toe would be a localized infection. It's localized to one area or one organ. Okay, so again, cause and effect. What happened first? What happened second? What were they admitted for? Now, we need, as with all post-procedural complications, code assignment is based on the provider's documentation of the relationship between the infection and the procedure. Okay, so again, post-procedural infections, we need to have clarification that it was the procedure that caused the infection. Okay, we need clarification and a direct link in documentation. Now, for such cases, the post-procedural infection, such as T80.2, infection following infusion, transfusion, or therapeutic injection, T81.4, infection following a procedure, T88.0, infection following immunization, or 086.0, infection of obstetrical surgical wound, should be coded first, followed by a code for the specific infection. If the patient has severe sepsis, the appropriate code from subcategory R65.2 should be assigned with the additional codes for any acute organ dysfunction. So again, cause and effect. What do we know? Again, was this due to a procedure? If it was, what goes first is what happened. So it's an infection following what? And then the code for the infection. They have severe sepsis, an R65.2 code with the acute organ dysfunction code following. So again, it all depends on the scenario. How does the provider describe it? Now, in cases where post-procedural infection has occurred and has resulted in severe sepsis, the code for the precipitating condition, such as T81.4, infection following a procedure, or 086.0, infection of obstetrical wound, should be coded first, followed by the R65.20, severe sepsis without septic shock. A code for the systemic infection should also be assigned. So again, what happened first? Whatever it was, obstetrical wound, infection due to a procedure, then we're going to put the infection code, then the severe sepsis, if they have severe sepsis, then the organ failure. If it's septic shock, it's going to be R6521, and then any other organ failure. So again, as it goes on, if a post-procedural infection has resulted in post-procedural septic shock, the code for the precipitating complications, such as T81.4, infection following a procedure, or 086.0, infection of an obstetrical wound, should be coded first, followed by a code T81.12, post-procedural septic shock. A code for the systemic infection should also be assigned. So again, think of it as what's the underlying condition, okay? So the underlying condition in this case, let's say, was infection following a procedure. Okay, what happened next? What is the infection? Then they have septic shock, R65.21, and any other organ failure. So again, lots of sequencing rules here, but also keep in mind, this is on the inpatient side. Now, it goes on, that SIRS I was talking about. In some cases, a non-infectious process, such as trauma, may lead to an infection which results in sepsis or severe sepsis. If sepsis or severe sepsis is documented as associated with a non-infectious condition, such as a burn or serious injury, and the condition meets the definition for principal diagnosis, the code for the non-infectious condition should be sequenced first, followed by the code for the resulting infection. If severe sepsis is present, a code for the subcategory R65.2 should also be assigned with any associated organ dysfunction codes. Okay? It is not necessary to assign a code from subcategory R65.1, systemic inflammatory response syndrome, for non-infectious origin for these cases. And the reason is because a non-infectious condition, such as a burn, led to an infectious condition. Okay? So that means we move it over to R65.2. R65.1 is only for patients that have SIRS, systemic inflammatory response syndrome, again, of the non-infectious origin. So that has to be documented by the provider for us to use R65.1 versus R65.2 for severe sepsis. Now, If the infection meets the definition of principal diagnosis, it should be sequenced before the non-infectious condition. When both the associated non-infectious condition and infection meet the definition of principal diagnosis, either may be assigned as principal diagnosis. So again, we need to know what was going on, why was the patient admitted, and also what is the principal diagnosis. Sometimes we have a coder's choice. It can be an either or, such as in this case. However, only one code from category R65, symptoms and signs specifically associated with systemic inflammation and infection, should be assigned. Therefore, when a non-infectious condition leads to an infection resulting in severe sepsis, assign the appropriate code from subcategory R65.2, severe sepsis. Do not additionally assign a code from subcategory R65.1, systemic inflammatory response syndrome of a non-infectious origin. So again, this is backing up what I was saying. We need to know if it became infectious, then it's an R65.2. If it's just SIRS, it's R65.1. There are separate guidelines going for sepsis and septic shock that we looked a little bit at. The rest of them are going to be in our O code guidelines for chapter 15. Also, for our P codes for our newborn sepsis, we'll see that for chapter 16. So we're going to start talking about MRSA and MISA. Okay, so for MRSA. So as I said earlier, MRSA is methicillin-resistant Staphylococcus aureus, and the infection has a combination code that includes the causal organism. Okay, so we have things like MRSA pneumonia, MRSA sepsis. Okay, in this case, we're going to assign the appropriate combination code for the condition, like A41.02, sepsis due to methicillin-resistant Staphylococcus aureus, or J15.212, pneumonia due to methicillin-resistant Staphylococcus aureus. All right, so when we have combination codes for MRSA, we are going to use the combination codes. The other thing to keep in mind is when we have a combination code, we are not going to assign things like B95.62 MRSA as the disease classified elsewhere as additional code, because the combination code includes the type of infection and the MRSA organism. Also, we do not assign a code from subcategory Z16.11, resistance to penicillins, as an additional diagnosis. And this is because MRSA is methicillin resistant. The methicillin resistant is resistant to penicillins. Okay, so again, we need to know what type of MRSA is it? What type of infection is it? Now, when there is documentation of a current infection, like a wound infection, a stitch abscess, a urinary tract infection due to MRSA, and that infection does not have a combination code to include the causal organism, assign the appropriate code to identify the condition along with B95.62, MRSA as the cause of disease classifiable elsewhere. And again, we still do not assign a code from subcategory Z16.11, resistant to penicillin. So again, we have a lot of combo codes for MRSA. Again, this goes for the entire book. If there's a combination code that describes your condition, you always go for the combination code. You do not break up the codes. That's what we call unbundling, okay? So, again, if there is MRSA pneumonia, it's a combo code, use a combo code. If it's MRSA due to a urinary tract infection, we're going to have two codes. First code is going to be like the urinary tract infection. Second code is going to be B95.62. Now, the other thing that's interesting about MRSA and what we call MISA is that you can just carry it in your body, usually in your nasal passage. So the condition or state of being colonized or carrying MISA or MRSA is called colonization or carriage, while an individual person is described as being colonized or being a carrier. Colonization means that MISA or MRSA is present on or in the body without necessarily causing illness. So again, it's just there. It does not make the person sick. Now, a positive MRSA colonization test might be documented by the provider as a MRSA screen positive or MRSA nasal swab positive. In that case, assign code Z22.322, carrier or suspected carrier of MRSA for a MRSA colonization, or Z22.321, carrier or suspected carrier of MISA for a MISA colonization. Again, as it reminds us, colonization is not necessarily indicative of a disease process or as the cause of a specific condition the patient may have unless documented by such a provider. So again, you can just be a carrier, you can have MRSA, or, as we're going to look, you can have both. So, if a patient is documented as having both a MRSA colonization and an infection during hospital admission, code Z22.322, carrier or suspected carrier of methicillin-resistant Staphylococcus aureus, and a code for the MRSA infection may both be assigned. Again, because they have both. And sequencing on that is going to depend on what else is going on. The MRSA infection, if that's what they have, would go first, then the carrier, suspected carrier. But again, if it's a MRSA infection in the urinary tract infection goes first, then the MRSA, then the carrier. Now, this is new. Anytime you see the bold, again, this is going to be new for this year, and this is for the Zika virus infection. So remember, Zika virus is being transmitted mainly by mosquito, but also by some sexual contact for people who have already been infected with the Zika virus. So, code-only confirmed cases of the Zika virus, which is A92.5 Zika virus disease, as documented by the provider. Again, this is an exception to the hospital inpatient guideline. In this context, confirmation does not require documentation of a type of test performed. The physician's diagnostic statement that the condition is confirmed is sufficient. The code should be assigned regardless of the stated mode of transmission. So again, if we already know the patient has the Zika virus in their body, just like if we already know the patient has HIV in their body, okay, the provider's documentation that they have it is enough for us to code it as the disease, okay? However, if the provider documents suspected, possible, or probable Zika, we do not assign code A92.5. We assign codes explaining the reason for the encounter, such as fever, rash, or joint pain, or Z20.828, contact with and suspected exposure to other viral communicable diseases. The other thing that we have to keep in mind is, of course, babies born from mothers and or fathers infected with the Zika virus. Again, Zika leads to microcephaly, so a very small head, usually a very small neck, and again, their head is much smaller, disproportionate to their body. And so, again, sometimes if we already know that mom or dad has Zika in their system and the baby is born and has microcephaly when they're born, again, we're still probably going to do that blood Zika test. But again, Z92.5, if the doctor says, this is my confirmation. However, if we don't know yet, if we're coming in for testing, someone went down to South America for travel and they got bit by a whole bunch of mosquitoes and now they're concerned, again, we have the contact or expected, exposure to, and then we also have the actual, reasons for the encounter, the signs and symptoms, if we're still not sure. So again, we need to kind of know what's going on, and confirmation needs to come from the provider's statement. So that's the big thing. So let's go back to ICD-10 data, and let's look at a couple of these sections. So what I like to do after I go through guidelines is I always like to go back to the beginning of the actual tabular. So I go directly into the tabular and I look at what are the groupings of codes, what are the categories of codes. So these are going to help you with thinking about what are my search terms. Two main search terms that you're going to look for is going to be under infection and under virus. You're also going to see a lot of kind of eponyms. Again, you can look Zika up under Zika. You can look under HIV under human immunodeficiency virus. But we're going to see everything from intestinal infections, tuberculosis, the zoonotic bacterial diseases. So again, we can click on this. This is everything from the plague to anthrax, rat bite fever. Again, these come zoonotic. They come from animals. So this is where we're going to see rabbit fever from, cat scratch fever, because there are certain infections, certain bacterial diseases that can transfer from animal to human, and so they're grouped in there. There's other bacterial diseases, infections with the predominantly sexual mode. So you can see everything from syphilis, gonorrhea, chlamydia, and different types of herpes infections as well. We are also going to see our other diseases caused by chlamydia, again, and spiritual diseases, rickettsiosis, viral and prion infections, arthropod-borne viral fevers. Again, those are our nasty bits. Those are our parasites. We're going to have other herpes virus, our viral hepatitises, our mycoses. These are caused, remember, myco is fungus, so our different funguses such as candidiasis, which is very, very common on and in the skin and mucous membranes. We're also going to see the helminthiases. These are the different types of worms that we can get, both in our intestines and in our body. And of course, we're also going to have things like the pediculosis. These are things like scabies and lice. Again, remember, it's viruses, fungi, parasites, and bacteria in this section. Then we have, again, the sequelae. Don't forget, we have sequelae of different infections. So we have sequelae of tuberculosis, poliomyelitis, which is the full term for polio, and leprosy. And then, of course, we get back to our B95 to B97s that we've looked at and our other infectious diseases, which are very unspecified. So we're going to go back to, the codes. We're going to go to the index this time. And I want to look under the words infection, and I want to look under the words virus. So again, we looked under the term infection. So again, infection, what type of infection? So again, a lot of times you're going to see some very strange terms. Sometimes they're going to be in italices. If you see anything in italics, that usually means it's an infectious disease, and you should look under infection. And again, this just keeps going and going. This goes on for multiple pages in your code book. You can see me scrolling down. I'm only through the C's right now. So we have a lot of things that we're going to find under the term infection. So we have to make sure that that's what we're looking at. So the other main term that we're going to see is going to be virus. And this, I'm just going to scroll down to it. So under virus, again, we don't have nearly as much, but we do have some. And again, see also condition. What's the condition of the body? What is the condition of the infection? All right, so what I want you to think about when you're thinking about infectious and parasitic diseases, we have a couple main chunks that have guidelines. HIV, sepsis, severe sepsis, septic shock, MRSA and MESA, and Zika. So again, those are the things that you should think about. One of the things that may be helpful to you is to actually go into your tabular and to highlight the codes that have guidelines with them, or to highlight the category, or circle it or notate it to let you know. So you could highlight B20 in blue, and you know the blue highlight means that there's a guideline about that. So remember, the notations you make in your book are to help you. And again, I'm just making suggestions, but in general, this is what I want you to keep in mind. All right, happy coding, guys.